Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. As usual, we have an excellent show for you today. We are going to talk about the foot, and it's called podiatry. I love that word, podiatry. All right, but first, before we get into the topic of today, I'd like to talk about caring and sharing. Remember, www.medmoments.com. Don't forget the S. That's medmoments.com. You can email me. Let me know what's going on out there. Let me know about any ailment that you're having, and maybe we can take it up on the show so you can learn more about it, and I can learn a little bit more about it myself. Also, you can tweet me. Tweet me at medmoments. Don't forget the S. Now, let's talk about podiatry. Podiatry is the study of the foot, and I have the perfect person to talk to us about that today. Her name is Dr. Patricia William Bennett, and she's a podiatrist. Dr. Bennett, welcome to our show.
Thank you, Dr. Bang. Glad to be here.
Yes. Well, I'm going to start off with a very, very basic question, and just give me some idea of what podiatry is.
Podiatry is the treatment and care of the foot, ankle, and soft tissue to the leg, depending on the state. The scope of podiatry varies according to state. Right. In New Jersey, we treat the foot, the ankle, and soft tissue up to the tibial tuberosity on the leg. In other states, they go all the way to the hip. In New York, they just do the foot. Okay.
Now, when you say tibial tuberosity, I love it. Go ahead. Where are you talking? Are you talking up to the knee, or are you talking below the knee? Where are
I'm talking to that little bump that's right below the knee.
Okay. All right then. So anything that's wrong with any patient, from that bump down to the tip of your toe, that's what you take care of.
Exactly, in the state of New Jersey.
In the state of New Jersey. And that's where you practice, so that's what we're talking about. Okay, now let's just step back for a minute, because this is such an interesting specialty, number one, and an interesting topic. Tell me, how do you become a podiatrist? What's involved?
Basically, there's seven schools of podiatry. It's a medical school. It's 4 years of study after college, and then there's also clinical training through a residency, which is now 3 years.
Oh, all righty. So it's actually a medical school that you go to?
Yes.
Oh, all righty. So the letters behind your name is DPM?
Yes, DPM stands for Doctor of Podiatric Medicine.
All righty, excellent. So if you want to study the foot, the ankle, and part of the lower leg, then you are a podiatrist.
Yes, actually, during our course of training, we study the entire body, and then we focus on the lower extremity. We study the body from the head to the toe, and then we concentrate many more months on the lower extremity. Just as a dentist would concentrate on the head, neck, in that area, we concentrate on the lower extremities for a longer period of time.
That's excellent. And I'm glad you brought that up, because the body works as a whole.
Exactly.
So you can't isolate the foot and the lower extremity from the rest of the body. So if something's happening with the heart or something's happening with the lungs, it's affecting that leg.
Exactly.
Excellent.
And that's what we try to tell our patients, that whatever is going on in the foot does not just stay in the foot, it becomes systemic. Right. So it can spread throughout the body. If you have an infection in the foot, that same blood that's circulating through the foot is circulating through your brain, your lungs, and all other organs of your body. All
righty. Now, if something's occurring in the foot or the leg, and it's affecting another organ, do you call other doctors in to help you out or anything like that?
Absolutely. It's a team effort. Complications of the foot, you need an entire team. We need blood. We need vascular surgeons. We may need a general surgeon if we need to have a graft. Also, the patients come in with other comorbidities or other problems. They don't generally walk in with just a foot problem. They may have hypertension, they may have COPD or pulmonary issues, diabetes, they may be renal patients, dialysis patients. So we need to know how the entire body operates.
Right. Excellent. Now, tell me what a typical day is for you in your office or at the hospital. What do you actually do? How do you conduct all of this stuff?
In a typical day, I would start off in the morning like a general physician. I would go to the hospital, I would do my rounds, I would see patients who are in the hospital. In this particular situation, more often than not, I'm called in as a consultant. I can admit patients also directly or through my office, but generally what happens is a patient presents to the hospital with some other type of disease entity, and the doctor will examine the patient, will find out they may have an ulcer or foot infection, or the patient may complain of pain, and then they will call in a specialist.
Alrighty, alrighty. And then what you'll do is you'll take care of that aspect for that particular team, working with that team.
Exactly.
Alrighty, alrighty. Now, because you're talking about pain, and I'll tell you just a little short story. One time I do a lot of walking during the day, and I had these shoes that kind of wore on my little toe there, on my left side. And you're talking about there's nothing more evil than me with foot pain. I'll tell you that you can't get any eviler than that. I'll tell you.
Exactly.
So I really appreciate what you do, and I respect it 100% because I'm telling you, I needed your services. Alrighty. So let's just step back for a second. I know that there are different things that you do in your specialty. And I know that you conduct examinations and stuff like that. How would you approach the patient that came to your office for a particular problem? Like either if they had pain or if they were, there was some discoloration. How would you approach that patient? What would you do for them? Okay,
generally when a patient walks into the office, I'll ask them what is their chief complaint. They may say, I woke up in the middle of the night, my foot was paining me, I couldn't walk. I couldn't stand for the sheets to be on the foot. I will generally go over their medical history. I will ask them if they have any past medical history, diabetes, hypertension, elevated cholesterol, what type of medications they take. I will examine the foot, check their pulses, check their neurologic standing to see if they have feeling in their feet, and also to look at the area to see if it's painful to touch. If it's discolored, discoloration, that's a red flag. And get a little bit more history. But certain statements they can make, automatically it'll trigger a diagnosis in my head. For example, if they come in and they'll tell me that their foot is red and painful, they couldn't stand on it, or they couldn't stand to have the sheet touch their foot, automatically I start thinking about gout.
Oh, all right. So a history is very important.
Yes.
All right. Now, so after you've given the history, after you examine the patient, are there, I'm sure there are minor procedures and stuff that you do in the office as well?
There's some minor procedures, and one of the basics that we would do is get an x-ray. If we need an x-ray, we would get an x-ray, or also injections. We do injections in the office. Some of the small surgical procedures we no longer do in the office. We may take them to a surgery center. If they have bunion pain or they want surgical correction, we'll explain surgical options and we can set them up for surgery. We can do biomechanics. We can have orthotics, inserts made for their shoes. And also we prescribe drugs, medications, if they need antibiotics, if they need pain medications. We can do all of those things too.
Excellent, excellent. All right. Do you, like for instance, I know that orthopedists do casts and stuff, but do you do the casts as well as like for fractures and stuff like that?
Absolutely. We do casting for, and also surgical correction of fractures, surgical correction of deformities of the foot, angulations, and we can also give people palliative care. Sometimes you have a non-surgical option. In certain instances, you don't have an option not to have surgery. For example, if I'm called in on a case in the hospital where the foot is discolored or gangrenous and there's poor circulation, I was called in just yesterday on the case, and as soon as I saw it, I knew that it was an ischemic foot, meaning no blood, no circulation, large ulceration, and that the foot probably was non-viable, meaning that it was going to lead to a limb amputation.
Oh, goodness.
So we also do amputations, but only up to certain levels. And if it goes above the knee or it becomes extensive, then we would call in the vascular surgeon.
Okay, so what you're saying is that that particular patient, the blood flow was not getting to certain areas of the foot, so that tissues of the foot actually died because they had no blood flow?
Exactly, that's the definition of gangrene. Gangrene is the death of tissue due to the lack of blood.
Oh, goodness, goodness. Now, can that increase the chance of infection as well, just because there's no blood flow in that area?
Absolutely, absolutely. The wounds are generally infested with a myriad of different types of bacteria. So we would take a wound culture, and then we would use that to determine what type of antibiotic the patient would need.
Okay.
And also, depending on the bacteria, the patient may have to be put into isolation, and we also may have to call in ID consult or infectious disease to help us manage the antibiotics, because more than likely they're going to be on more than one, maybe two, maybe three. Sometimes I've seen them on 5 antibiotics.
Okay, alrighty. Now, you were talking about you know, vascular surgeon. I know you brought these words up, and you mentioned a lot that I want to get back to. But surgeons. Now, I understand that you are a surgeon, podiatrist, and there are some podiatrists that obviously don't do surgery.
Exactly.
Alrighty. Now, the type of surgery you do, is it, I know that sometimes the ulcerations, sometimes you have to clean them out, or are there patches that you can put on it, or how do you, I know ulceration is a problem for the elderly. I know a lot of the patients that may be in the nursing home or maybe in beds for a long time, or for whatever reason they may get ulcers. How do we handle those ulcerations?
Right. Ulcers are a result of pressure. And also a result of neuropathy. When the patient has lost feeling, they may not even know that they have a tack or a toy or something in their shoe, and it rubs a sore. We find that oftentimes with diabetic patients where they don't have good feeling. Also, if a patient is immobile and lies in one spot for a period of time, the tissue may break down. So we would have to do what we call a debridement, where we would take a scalpel and remove all of the dead tissue in order to get down to the level of viable, healthy tissue. And more often than not, we would do that in an operating room. We also have something called hydrosurgery, where we have a mechanical instrument that can cut and irrigate at the same time.
Okay. So what you want to do is you want to cut all the dead tissue away so that the good tissue can heal.
Exactly.
Basically, am I explaining it correctly?
Exactly.
Alrighty.
But one of the problems we encounter is sometimes, like diabetic patients or patients who are compromised, they don't epithelialize or create new tissue. So sometimes we may have to do a skin graft. We have a lot of different biomechanics that we can do, and also allografts, different types of grafts that we can do to add tissue to the body. If they don't have good tissue themselves, we have artificial tissue, we have tissue from animals that we can use. We have wound care clinics, and at Newark Beth Israel we have a huge wound care clinic where we can do very specialized procedures, including hyperbaric therapy. Oh
goodness, we'll have to, hopefully we have time to mention that. Now the thing of it is that I understand, so you said something, you said neuropathy. Neuropathy. What exactly? I understand that has to do with the nerves, right?
Yes, exactly.
And diabetes, not per se the vessels, but that's the nerves. How does that work?
Yes, one of the determinations that we have to make with ulcerations is whether or not it's a result of a vascular compromise where they don't have enough blood flow, or if it's neurologic, neuropathy. Neuropathy occurs when there's accumulation of probably like glucose in the vessels in a diabetic patient, and the nerves don't fire properly. So they have no feeling, and they may walk around, they may have a shoe invariably that's rubbing, or something that's rubbing, and it rubs a sore and they don't feel it. So neuropathy, the problem is there are not a lot of ways to reverse neuropathy. So the best way to prevent it is to manage the blood sugars so that you don't get into that state.
Right.
And you can get other types of neuropathy too, alcoholic neuropathy from other disease entities, or trauma where a nerve is severed, you can get neuropathy. But anytime you don't have feeling, then you're also prone to have some type of ulceration.
Yeah, so you mean that you can actually hit your toe, you can be bleeding, or it can be, you have a big cut on it and you not even know because you can't feel it.
Absolutely.
So it gets worse and worse and worse simply because you can't feel it.
Absolutely.
Oh, all right then, all right. Now let's go, let's talk about sports. Because that's a big thing. I have a son that plays football, and he had a high ankle sprain, and boy, believe me, I understand lower and the foot and ankle and all. We went through it all this year. But tell me about sports and your foot, and how you can protect those young people, even older folks who are out there doing sports, because we're all trying to stay more active.
Well, The function of the foot is ambulation, and the foot is a very unique organ because it carries weight. It is weight bearing. So therefore, 2.5 times your body weight goes through your foot every time you take a step. So with sports, it's important to have your foot balanced, and also proper shoes. Proper shoe gear, protective shoe gear, proper shoe gear in sports, and also in everyday ambulation and living. That's one of the problems that we encounter. People don't wear the right types of shoes. And we can also use these devices called orthotics or inserts to balance a foot, because some people have very low arches, some people have very high arches, and that can cause a lot of problems.
Okay. Now, what about as far as running and like you said that 2.5 times your weight? Is that because of gravity pulling you down? Or
that's because of gravity. That's because of impact.
Okay.
The way you run, the way the joints are move, and especially your first metatarsal phalangeal joint, this joint. Because you push off, you have a propulsive type of gait. When you run, you push off actually on your toes. People don't even realize it, that you have to bend your foot in order to run or to move. And also impact, bouncing and hitting the ground, or people playing basketball, they're jumping, soccer where you're kicking. So a lot of force goes through these joints.
Okay. Now, when you're talking about that joint, you're talking about the one, that particular, you're talking about the joint around the big toe?
Yes.
All right.
Yes, yes, that's the joint.
That's the one you're talking about.
Yes.
Hey, give me the big toe right there.
Exactly.
I got you.
Exactly.
All right. Because that bears a lot of our weight, is what you're saying.
Yes, it does.
So it's very important to the foot. So if someone has an amputation of the large toe, it really creates problems as far as walking and maneuvering, then, you would say.
Exactly, because you do not have that joint, that toe to push off on. And then you get what we call transfer lesions. The metatarsals are supposed to carry a certain amount of weight. But when you have one that's missing, or a toe that's missing, then the other toes have to compensate for that loss, and they may bear 2 or 3 times their weight, and then you'll get a lesion under one of those metatarsals. So it just transfers from the first to the second to the third to the fourth, and then you have to balance the foot. So that's where you would use a custom orthopedic shoe or some type of insert, biomechanical insert.
Right. Tell me about weight, and we were talking about weight as far as weight, you know, the amount of pressure that you put on your foot. If an obese person has foot problems, does that play into the feet becoming more prone to trauma, or to infection, or to ulceration, or whatever you, does that play a role?
Absolutely, absolutely. And one of the major complaints that presents to our offices, heel pain. Heel pain, and from heel spurs. And it's not the actual spur. The spur is an outgrowth of bone on the calcaneus, or the heel bone. But it's really not that bone that hurts. It's the muscles. You have 4 layers of muscles on the plantar aspect of the foot, and it's the pulling of those muscles on that particular bone. So with heel spurs, we have this acronym, the 3 Fs, fat, female, but it doesn't always have to be female, and 40. Those are presenting factors. But weight, absolutely, you make our job much harder if you are overweight, as far as balancing the foot.
Right. Well, I know that some of my patients that come to the office, and they're very overweight, and you can see that if you look, they have a lot of swelling in their lower extremities. And because of that, the certain amount of blood flow may not get to it. Do you find that, you know what I mean, that makes your job even harder as far as trying to heal these or trying to take care of it?
Absolutely. We have these ulcerations called venous stasis ulcers, and it's right around the ankle area where it becomes darkened, and a lot of times that area will break open and erupt, and you'll get an ulceration because of the blood flow. The valves in the lower extremity are not good, and when that blood flows to that area, it just kind of pools there. The blood cells rupture. They have a pigment called hemosiderin. They rupture, and you get that dark pigmentation. And we have a very difficult time trying to close those ulcerations. I've seen patients who've had ulcerations open on their ankles for over 20 years. So they're prone to infection, constant bouts with the hospital, in and out. And we always tell patients, when you present to the hospital with a foot infection, you're in for a long time. You could be in the hospital 4, 5, 6 weeks. easily with a foot infection. They're extremely complicated, and you can get what we call sepsis.
Okay, all right. Now, is it one of the things I understand that the muscles in the planes of the foot makes it very difficult too, because there are certain muscle planes and tissue planes that the infection can get in between, and it's very hard to cure that infection?
Absolutely.
All right.
The pus or infected material can traverse, you're right, through the muscles in the foot and can be trapped. And in that case, you can get situations called gangrene, gas gangrene, which is a medical emergency, and the patient maybe have to take them to the hospital in the middle of the night and do an amputation, because it can circulate through the body to the heart and it can cause death. And it's a necrosis, it's a tissue necrosis, and it moves rapidly, and the goal of the surgeon is to get ahead of the infection before it ascends, up the body. Okay. And that's also a place where we can use hyperbaric oxygen therapy.
Okay, now that you mentioned hyperbaric, let's just go into that just for a second. You're talking about a chamber or like a big tube or something like that that has a very high concentration of oxygen.
Exactly.
Explain this. How does that help infection, or how does that help the wound? Tell me what's going on.
Well, this high concentration of oxygen, it stimulates what we call angiogenesis, so it helps blood vessels to reform, it increases the circulation.
Okay, so angiogenesis is new blood vessels growing.
Exactly.
Oh, okay, I got you.
Exactly.
Okay.
We cannot heal any type of ulceration without blood. I always tell patients that blood to the body is just like oil to an engine. Right. Cannot function without blood. And also, in various ulcerations or wounds, we have organisms that are called anaerobic organisms. Anaerobic organisms grow in the absence of oxygen, and they don't like oxygen, so you can kill off the anaerobic organisms with hyperbaric therapy. So
let me get this straight now. You're going to put my leg in this chamber, pump up the oxygen way, 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 way high, and kill those bugs.
You kill the anaerobes. But it's not, hyperbaric medicine is, you have to put the entire body into the chamber.
Not just the leg.
No, head to toe. It's a glass chamber, the entire body. There are contraptions where you can just put the leg, but they don't consider that to be hyperbaric medicine.
I got you. Interesting, very interesting. Let's talk about cancer in your specialty. Let's just cover that just for a second. Okay.
Yes, most people do not know that there are a lot of cancers in the foot. We have all types of tumors in the foot, in children, in adults.
Right.
And about 2 years ago, I had a case that presented at one of my hospitals, actually to my office, a very tiny lesion on a 22-year-old male, half the size of a green pea. And it ended up being an epithelioid sarcoma, a very aggressive tumor, and the young man lost his leg above the knee. And this was just on the toe, which we thought that if we went in, I thought it was just a typical hammer toe. But when I operated, I sent the tissue to pathology and asked them to rule out neoplasm or cancer. And it came back as a cancer, a very vicious cancer, but it had already metastasized or spread up into the tibial area.
Oh, goodness.
So he lost his leg. So yes, you can, any disease state that you can get in one part of the body, you can get in the foot. And yes, cancer is included.
Okay, we didn't cover corns or bunions. Real quick, let me just get an idea. Number one, what are they? And number two, how to best take care of them.
Okay. Corns and bunions, they are basically the staple of podiatry.
Okay.
And a bunion is a deviation in your great toe when it's not straight. This first metatarsal phalangeal joint here. And generally there'll be an outgrowth on the side. It's very painful. A joint is the space between bones. So anytime you lose that space, it's like an arthritic joint, and it's painful. And when the toe deviates, people have trouble in the shoes, and it's a rubbing from the shoes, and it gets inflamed, very reddened. So we can correct that surgically. It cannot be corrected without surgery, but we can have a palliative care where we can give you an insert and make you comfortable. But we will give you the surgical, non-surgical options. A corn is really a lesion that grows. We have what we call a crooked toe or a hammer toe. That is a clinical term, a hammer toe. And from the rubbing of the shoe, the body creates this corn or this thickening. And so we can surgically correct that. And if you don't want surgery, we can give you some palliative care.
All right.
to see if it works.
You know, we run out of time, and there's so many more things I want to ask. This is such a great conversation. And thank you very much, Dr. Bennett Williams, Bennett, for coming in to see us and talk to us and just give us a wealth of knowledge about podiatry and about the foot. Thank you very much.
You're more than welcome.
All right.
Thank you.
Just to sum up, I just want to talk real quick about, and this is our Let's Talk segment. We only have a short amount of time, but we're going to do it anyway. It's called the stress test. And I just want to tell you that to evaluate the heart, we use this test to evaluate the heart, to see how the heart is pumping, whether it's pumping enough blood. And basically, you get on a treadmill and you start walking, and there are different aspects of this treadmill. Basically, we monitor the heart. You walk, first we start slowly in walking, then the treadmill will tilt, and it'll tilt up just a little bit, so you're going up an incline, and then we'll speed it up. And what we want to know is that if your heart is pumping efficiently and appropriately, doing a little exercise. That tells us how the heart's pumping, whether the blood is going to the heart appropriately, exactly what's the condition of your heart at that particular point. Okay, so we look at heart rate, we look at breathing, and we look at blood pressure. So it's very important to get a stress test if you think you may have any heart disease. Well, it's at the end of our show, and in closing, remember, sharing and caring. Email me, www.medmoments.com, and you can tweet me too, @medmoments. Also, never institute any change in your medical therapy before you consult your physician. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.